Good morning to all. First, I would like to thank Veena ma'am and Frederick sir for giving me this opportunity. Topic for today's talk will be on physiological perspective and biometric changes in myopia. Before going to physiological aspects, and we'll go into certain basics. Emmetropia, it is when parallel rays of light coming from infinity are focused in sensitive layer of retina with accommodation being at rest. What are the factors which help in emmetropization during growth are axial length, corneal curvature, anterior chamber depth, and lens thickness. And coming to myopia, when parallel rays of light coming from infinity are focused in front of retina with accommodation being at rest. Okay, as shown in this picture. Why it is important? It is most common refractive error in pediatric population in India. Its increase in prevalence rates from 4% in 1999 to 21.15% in 2019. It's predicted to rise to 31% in 2030, 40% in 2040, and 48% in 2050. Myopia is classified based on etiology and clinical. Etiologically, it is classified into 4 types: axial myopia, curvatural myopia, index myopia, and myopia due to excessive accommodation. Axial myopia, it results from an increase in anteroposterior length of the eyeball. Curvatural occurs due to increased curvature of the cornea or lens or both. Index myopia, it's increase in refractive index of the crystalline lens associated with nuclear sclerosis. And myopia due to excessive accommodation occurs in patients with spasm of accommodation. Clinically, it is classified into congenital, simple, pathological, or acquired myopia. Congenital myopia, it's usually present since birth. Usually, the power will be around 8 diopters, and it's almost constant. It's more seen in children with ROP and other birth defects. And simple or developmental myopia, it's seen in normal biological variation in the development of eye. Pathological, it's due to rapidly progressive error, resulting in eye myopia apparent during the first decade of life. It's due to increase in volume of posterior segment. It's more seen in 0.9 to 3% population. Okay. Then acquired myopia is like index myopia, pseudomyopia, and consecutive myopia. Now our topic of interest will be more on simple or developmental myopia. Coming to physiological perspectives, we'll see this in under 5 topics: ethnicity, genetic factors, accommodation, illumination, and outdoor exposure. Simple myopia varies greatly in different ethnic and geographical population. According to the study in American preschool children done between 6 months and 6 years, prevalence of simple myopia is more common in African Americans, around 6.6%, followed by Asians, 3.98%. According to Wen et al., prevalence is 6-fold more in 12-year-old and 3-fold more in 17-year-old when compared to European Caucasians. East Asian ethnicity has more prevalence of myopia. Genetic factors, the increased risk of myopia is highly correlated with number of myopic parents, and the risk is independent of environmental factors. According to genome-wide association studies, it identified correlations between variation in certain genes and an increased risk of myopia. According to CREAM study, it encompasses 32 studies, including Europe, United States, Australia, and Asia. 24 genomic variations were associated with up to 10% increase in risk of myopia. Variation involved in many unrelated ocular functions instead of single underlying system or structure. According to Verman et al., genetics may determine myopia susceptibility, such as age of onset, rate of progression, ultimate refractive error, but environmental factors are powerful modifiers of eye growth and they may override genetic predispositions. What are the environmental factors which involve in myopia progression? Increased socioeconomic status, residing in an urban environment, increased time spent performing near work, and increased indoor activities. Generally, in older days, people used to say watching TV close will increase your refractive error. The mechanism behind it is inhibiting accommodation does not prevent myopia. That is, when near work is increased, it causes accommodation fatigue, which causes ciliary muscle spasm. It leads to hypertrophic defocus and elongation of eyeball. According to COMET study, it is a 3-year study with 469 children. Randomized unmasked control study. Children were divided into 2 groups with the progressive additional lenses and single vision lenses. Spherical equivalent was less in progressive additional lenses when compared to single vision lenses, and axial length elongation was also less when compared to single vision lenses. Both were statistically significant, but this was done only in a very less number of children. So further, many studies are required to confirm this hypothesis. Then why outdoor activity is important? Outdoor activity helps in stimulating intensity or wavelength dependent anti-myopia systems in the retina. It causes sustained pupillary constriction via the melanospin system, thus improving retinal image quality by reducing longitudinal aberration. It increases the average viewing distance of objects outdoors compared to indoors, thereby reducing accommodative fatigue. It increases the activation of spatio-temporal image response mechanisms in the retina, which inhibit myopia development. High intensity illumination. According to Rose et al., myopia progression is less in children who play outdoors when compared to children who play indoors, corrected for their age, gender, everything. Based on many animal studies, sunlight exposure gives high intensity illumination, which increase neuromodulators like dopamine, nitric oxide production, which further inhibits myopia. Biometric changes. These are the 4 things you have to consider: axial length, anterior chamber depth, corneal curvature, and axial length corneal curvature ratio. At present, many studies have stated that axial length and corneal curvature ratio is more important in the diagnosis and progression of myopia. According to study by Zhang et al., correlation between refractive errors and ocular biometric parameters in children and adolescents. It is a meta-analysis. It included 128,178 subjects. M-metropes were 48,795. Myopes were 60,691. Based on this study, axial length was higher in IA myope cases, and which was statistically significant. And similarly, anterior chamber depth was also high in eye myope cases. And axial length corneal curvature ratio was high in eye myopes, and corneal curvature, it was high in moderate myopes. Lens thickness was less in eye myope cases. Coming to our own study, this is a study conducted in Aravind, Coimbatore. It is an ocular biometric parameters in South Indian children with myopia, a hospital-based retrospective descriptive analysis. It included 3,728 myopic children. All were between 5 to 15 years. 71% were between 11 to 15 years. And 1 mm increase in axial length leads to minus 1.65 increase of spherical equivalent. It was more between 6 to 10 years, which is around minus 1.85. Here, spherical equivalent was compared with axial length, corneal curvature, and axial length, corneal curvature ratio. Here also, as the myopia progresses, the axial length and corneal curvature and axial length, corneal curvature ratio increases, which were all statistically significant. Thus, myopia, one of the most common refractive errors seen in the Indian pediatric population, has various physiological factors which influence the onset and progression. Proper counseling and awareness about the do's and don'ts to parents of our young patients can significantly help in our approach, with most of this complication being irreversible and result in a permanent reduction in visual acuity. Ensuring adequate biometric evaluation also plays a major part in treatment. Thank you.